So welcome to the monthly COVID Neuro webinar. My name's Tom Solomon. I'm here at the University of Liverpool. And these seminars are run from Brain Infections Global, which is our global initiative on brain infections in partnership with the Global Health Network. You can visit the website, I know many of you have done, and you'll see the drop downs for our COVID Neuro work, including these COVID Neuro webinars and some COVID Neuro resources, such as our case record forms for capturing your patients with neurological disease, and also for recording adverse events. There's been quite a lot of activity in the space of adverse events. Now, these webinars are Brain Infections Global. This is a global network. You can join, you can visit the website, you can join as a member. It's great. If you sign up as a member, it means you'll hear about all the things that are going on. And we have input from countries all around the world. There are also teaching resources that we have, such as free online e-learning about neurological infections. And there are lots of other e-learning activities available through the Global Health Network. So our webinars bring people together who work on neurological problems of COVID-19 to help us understand these problems, including the long-term effects. They also help us keep up to date with the latest research. And immediately after this, we have the WHO Clinical Exchange Network. A little bit more about that in a minute. Let me just at this point ask you, our audience, to post something in the chat, because we like to hear from you. So if you could find the chat function and then just post and say hello, tell us where you are calling from. And also there's Bandana Uniyal saying good evening to all. Where are you calling from, Bandana? And also, well, we've actually got some sunshine here in the UK at the moment. Please tell us, what is the weather like where you are? We're especially interested in, is it snowing anywhere in the world at the moment? Please do let us know and tell us where you're calling from, and also whether this is your first time joining the webinar, or whether you're a repeat offender who can't get enough and comes back for more every time. That'd be brilliant. We look forward to hearing your thoughts. And then also, when we're having our talks, please do post any questions or comments into the chat function, and I'll put them to the speakers there. And Angela Vincent is saying hello, stuck in her village outside Oxford. But Angela, we've had Freedom Day. We're now free to go all over the country and do what we want, where we want. Are we not? Okay, well, let's move on. So we have some absolutely fabulous speakers today. I'm really excited to introduce them. We have Shelley. Oh, I've gone too far. Sorry, go back a slide in my excitement. Farhadian, who is an infectious disease assistant professor, and also an assistant professor at the Department of Neurology, who's published some brilliant work in Cell Reports Medicine. And we saw that paper and we just knew we had to have her joining us. And then also we've got Amrit Dravid, who has been working on COVID in Pune, which is a really big virology center in India, and has been publishing on his experiences there. So we're going to hear those as well. And then in addition, Stuti Chakraborty is going to present at the half-time the highlights from the JNNP blog. She's been reading all the journals and will tell us what we need to know, because we know you guys are far too busy looking after patients to read them yourselves. So just also to remind you, immediately after this, we have the WHO COVID Neuro Clinical Exchange, where we get into some clinical management of cases, and we're going to be learning about cerebral mucormycosis, you know, this fascinating fungal problem that seems to jump on the back of COVID. And we've got Kameshwar Prasad and Divya Deodar talking about that. So like I've said, post your comments, questions into the chat function. And also, if some people I know are watching on Facebook, so if you're a Facebooker, you can post your question onto Facebook, and then someone will translate it over for us. And that's the tweet. That's my Twitter there if you want to tweet things. That's the date of our next webinar. And let me now hand over to Shelley to please tell us all about this fascinating work on neuroimmune responses during COVID-19, this single cell approach. I'll stop sharing my screen and Shelley can share hers. Thank you. There we go. That looks like it's coming up. Fabulous.
Cut to the cheese. Okay, great. Can you see that okay?
Yeah, we've got that. It's wonderful. Go ahead.
Fabulous. Well, thank you so much, Dr. Solomon, for including me. And I'm really, delighted and humbled to be included in the group that's presenting today, including my colleague, Dr. Dravid. So thank you so much. Today, I'm going to be talking about some of our work that we did with a cohort here in New Haven, trying to understand neuroimmune responses during acute COVID-19. So I'm going to try, because our time is so limited, to, as much as I can, focus on a specific case as an example of what we've been looking at. So this is a patient who I saw actually during our first week of patients with COVID-19 in our hospital last March. When I was attending in the hospital. So this was a 43-year-old guy who had a history of poorly controlled diabetes, and he came to the hospital presenting primarily with a mental status issue. On further questioning, his family said that about 2 weeks earlier, he may have had some dry cough and shortness of breath. And on admission, he was diagnosed by a nasopharyngeal swab with acute COVID-19, as well as diabetic ketoacidosis. He was treated for his DKA, but the mental status remained poor, and he underwent a full neurological workup that was really unrevealing, including lumbar puncture, and I've shown you the CSF studies here. So the question was this potentially, and again, this was our first case, so we really didn't know that much, was this potentially somehow related to his COVID-19? And so this patient generally consented to donate excess cerebrospinal fluid and blood for research studies. And so he was the first of several participants who joined the study, in which we studied paired spinal fluid and blood from COVID-19 patients and healthy volunteers to try to understand whether there were CNS-specific immune responses in these patients who had acute COVID-19. And I'll say that these patients were a small part of a much larger cohort that I helped assemble at Yale over the last year and a half, the IMPACT cohort. So I'm showing you here some of the other people involved in the leadership of this, but we've now enrolled over 350 hospitalized patients with acute COVID-19. From these patients, we collect clinical, demographic, and epidemiological data. All participants donate tissue specimens. In some cases that includes CSF, although usually not. And we also, within this larger cohort, have some special groups, including women who are pregnant with COVID-19, and those who have cancer and COVID-19, and others. So I'll be talking now about data collected from the first 6 participants who donated blood and CSF for these studies. This is a snapshot of some of the clinical characteristics of these participants. And I'll just point out that their ranges of age were from the 40s to the 80s. The neurological symptoms were encephalopathy, intractable headache, seizure, and not surprisingly, because this has been talked about in these webinars before, none of the CSF was positive for SARS-CoV-2 by RT-PCR. And really the CSF clinical labs were, for the most part, unremarkable, with a handful of slightly elevated protein. So the first thing we did was take the blood and the CSF, isolate the cells, and through single-cell RNA sequencing, characterize the immune cell landscape in these 2 tissue compartments during acute COVID-19. So what I'm showing you here are the immune cell populations that we uncovered in the CSF from the controls, the CSF from COVID-19 patients, and the peripheral blood from controls and COVID-19. And I want to highlight that this work was led by an MD PhD student, Dr. Eric Song. So once we identified the different immune cell types that were present, we next asked whether there were gene expression signatures that were found differently within immune cell populations in the CSF compared to the blood of COVID-19 patients. And I should say that at the same time, a separate group led by Hemming et al. Performed a similar study, and taken together, our results found that when we look at gene expression in T cells of the CSF in patients with COVID-19, we find upregulation of T cell activation pathways, increased IL-1 and IL-12 signaling, increased CD4 T cell exhaustion, as well as a clonal expansion of unique CD4 T cells that are expanded in the CSF and not in the blood. And when we separately looked at the innate immune cells in the CSF, we found an enriched interferon signature compared to controls. I want to highlight that these are findings that differentiate the CSF from the blood and really suggest that there may be divergent or compartmentalized immune responses occurring in the central nervous system in the context of this systemic infection. And so to further explore this and to follow up on those single cell results, we next measured 71 cytokines in the CSF and blood of our COVID-19 patients and controls. And we found that certain cytokines, including IL-1 and IL-12, were elevated in the CSF of our COVID-19 patients, but not in the plasma. And likewise, we found that cytokines that were elevated in the plasma of the COVID-19 patients were not elevated in the CSF. So again, this suggests that what's occurring in the CNS is not necessarily a reflection of what's occurring in the peripheral blood, but rather maybe compartmentalized immune responses. And I also want to highlight that it was interesting to us that the two of the most differentially regulated cytokines in the CSF were IL-1 and IL-12, which we independently found to be elevated through the single cell RNA sequencing as well. So what I've shown you so far has primarily focused on T cell responses in the CNS, but what about humoral or B cell responses? So as I think has probably been discussed in previous webinars here, many groups have now identified the presence of anti-SARS-CoV-2 antibodies in the CSF of patients with acute COVID-19. So to better understand the nature of these antiviral antibodies, we collaborated with Dr. Michael Wilson at UCSF. Dr. Wilson's group had recently developed a custom multiplex ELISA assay that simultaneously measures the blood or the CSF for antibodies that react against numerous SARS-CoV-2 epitopes. And to go through these results, I want to focus again specifically on that first patient, the case that I described to you earlier. So first, I'll just point out that at the top is the healthy controls. And as you can see, none of the healthy controls had immunoreactivity against any of the SARS-CoV-2 epitopes that were tested, which is not surprising, but reassuring. When we look then at this COVID-19 patient, for example, we see that this patient had antibodies against total spike, against the receptor binding domain, not against nucleocapsid in his plasma, and against several other SARS-CoV-2 epitopes. When we look at his CSF, again, we find the presence of anti-SARS-CoV-2 antibodies, but importantly, the antibody profile was different in the CSF when compared to the plasma. So for example, in the CSF, we can pick up the presence of anti-nucleocapsid antibodies, whereas those were not present in the plasma. And when we look at the other patients, other participants in the cohort, again, we likewise find that the epitope specificity differed for the antibodies found in the CSF compared to the plasma. These results suggest that antiviral antibodies in the CSF do not simply reflect passive transfer of antibodies from the periphery into the CNS, but rather they suggest that antibodies in the central nervous system may be being produced in response to a local antigen present in the central nervous system. Obviously, this does not prove that, but this is, I think, one step that led us to further try to explore that hypothesis. To do that, I wanted take a brief detour into the world of animal studies. So again, led by Eric Song and in collaboration with Akiko Iwasaki's lab, we asked whether the presence of antiviral antibodies in the CSF reflected the presence of viral antigen in the CNS using a really neat mouse model. So Eric and Akiko had developed a mouse model in which SARS-CoV-2 infection can be localized to specific tissue by having those tissues specifically express the human ACE2 receptor. So sort of skipping to the chase, by using this approach, we could produce mice that only had infection in their lung, had infection only in their brain, or had infection in both the lung and the brain. So now using these three different mice, First, we asked whether we could pick up virus in the CSF of these various animals. So looking now at the levels of viral titers in the brain, in the lung, in the CSF, and in the serum, you can see that in the mouse that had both brain and lung infection, the level of virus, not surprisingly, is detectable in the brain at day 3 and day 7 post-infection, and virus likewise is detectable in the lung. But despite robust brain infection, virus is never detectable in the CSF of these animals. In contrast, when we examined these animals for the presence of anti-SARS-CoV-2 antibodies, only the animals that had infection of the brain, in other words, these two models on the bottom, had detectable SARS-CoV-2 antibodies in the CSF. And so taken together, I think this really neat animal experiment suggests that viral load of the CSF may not be the most reliable detector of brain infection, whereas the presence of antiviral antibodies in the CSF, anti-SARS-CoV-2 specifically, are more suggestive of brain infection itself. So going back to the single cell data for a moment, one of our most striking findings was that B cells seem to be expanded in the CSF of our COVID-19 patients when compared to controls. So you can see that control CSF typically contains little to no B cells, whereas our COVID-19 patients had increased frequency of B cells in their CSF. And again, this is the data from that first participant that I told you about earlier. When we then look at specific B cell receptor clones in this patient, we find, not surprisingly, several expanded clones in the peripheral blood of this patient. But interestingly, we also find expanded clones in the CSF, including one B cell clone that comprised about 10% of all the B cells in that patient's CSF. So to kind of follow up on this, our question was, what are these specific B cell clones targeting? And are these clones targeting viral antigens, in which case this would support our hypothesis of localized antigen within the central nervous system driving this B cell expansion in the CSF. To get at this, we took these clones from the peripheral blood and from the CSF and produced patient-derived monoclonal antibodies from that first patient. We then tested these monoclonal antibodies that were derived from CSF or from blood for reactivity against spike protein. And as you can see, 2 of the peripheral blood-derived monoclonal antibodies and 1 of the CSF-derived monoclonal antibodies were immunoreactive against spike using this ELISA assay. Our next question was, what were these other monoclonal antibodies targeting then? If they weren't antiviral, why were they expanded in the CSF of our COVID-19 patients? And at the same time, reports had been coming out about potential autoimmunity in COVID-19 patients. So in collaboration with Chris Bartley and Sam Pleasure, again at UCSF, we took our panel of monoclonal antibodies from CSF and from blood and tested them for immunoreactivity against brain tissue using mouse brain immunostaining, in which the monoclonal antibody is incubated with rodent brain sections and counterstains with immunofluorescence. As you can see, several of the monoclonal antibodies derived from the CSF showed immunoreactivity against brain tissue. And interestingly, this included monoclonal antibody C2, which was the antiviral monoclonal that we had derived from this patient. This suggests some cross-reactivity between an antiviral antibody and an anti-neural reactivity. So in the interest of time, I'll just go on to say very briefly that we then took whole CSF from our COVID-19 patients and asked whether the CSF from those patients also showed immunoreactivity against neural tissue. And indeed, 5 out of our 7 patients did show some degree of anti-neural reactivity in their CSF. So in conclusion, our CSF study suggests that immune-mediated processes in the CNS may potentially contribute to neurological sequelae of COVID-19. We found evidence for increased T-cell activation in the CSF, that cytokine levels again reflect divergent responses in the CSF compared to the plasma, and that most of the neuro-COVID patients we've tested so far have autoimmune antibodies in the CSF. And I will stop there.
Thank you. Thanks very much, Shelley. That was super. I'm going to clap on everybody's behalf. People can please post their questions or comments now into the chat function. And we've got Angela Vincent. I don't know if you are able to turn your microphone on if you want to join the discussion, and camera. In fact, yeah, I think I can see you there. So Angela, if you want to actually ask your question, Shelley, if you don't know, well, you probably do know of Angela's work. She's a proper neuroscientist, and she's posted some questions. Angela, do you want to ask your question, or should I ask it for you? She might be struggling with the, she's a brilliant neuroscientist, but like all of us is probably struggling with the Zoom controls. Well, let me start. She's basically asking about dilutions of plasma and CSF.
So thank you, Angela, for that question. And so for the mouse brain immunostaining, which was work carried out at UCSF, I really want to highlight my amazing collaborators there. Oh, I didn't go to my acknowledgement slide because I was in such a rush. I'm so sorry. Oh, that's terrible form. But so Chris and Sam really led that work, which was quite novel. And they used serial dilutions, and we found that the CSF was immunoreactive at higher dilutions compared to the plasma. But Angela, we can, I can get back to you with more specifics on the exact dilutions for that, which are not coming to me right at this moment.
Great, okay, thank you. And let me ask a couple of questions. Kiran Thacker, who is also one of our team, so she's posting questions, but maybe everybody's being very shy today. Kiran, you can turn your camera on and microphone on and ask yourself if you want. And while she thinks about turning on her technicals, let me ask you, Shelley, well, I've got a couple of questions really. First of all, I mean, it's lovely work. I don't know, are you familiar with any of the similar work in tuberculous meningitis? I think people have been trying to use similar approaches there, looking at single cells. I don't know if any of that has got as far as this, but I'm
not familiar with using single cell RNA-seq of CSF in tuberculous meningitis. You know, we've been doing it in HIV, but in terms of single cell characterization of CSF during neuroinfectious diseases, it's still definitely an emerging field.
Yeah, maybe it was HIV work that I'd come across. This CD4 T cell expansion, has that been seen in HIV, in the CSF of HIV?
So we are just now looking at clonality of T cells in the CSF of HIV patients, but to my knowledge, this is the first time that immune repertoires have been assessed in the CSF in the context of an infectious disease, as far as
Thank you. Maybe I'm either misremembering or I've seen data, but it wasn't published. Kiran, go ahead.
Okay, I became less shy, I guess. No, really amazing work, Shelley, and to your team for, I think, this really incredible effort. I think it really gives us a lot of light into what potentially is happening in terms of neurological effects. I had a question, and I know you were part of a large team that was working in this kind of mouse model work that was then translated into humans. And I wanted to kind of understand some of the findings with regards to the staining in the lipofuscin-laden neurons, which the paper suggested was related to direct human infection of neuronal cells, and whether you think that finding may be specific. And then if you could also comment just in general on some of the kind of relevance of animal-based studies. I think we heard a great lecture last week in terms of how we can translate that into human models, which I think is obviously important work.
Yeah, you know, so Karen, I'm not familiar exactly with the finding that you're referring to, so I'll defer that for now. But with regard to the applicability of the animal study, so, you know, as we talked about during the NIH meeting last week, which was really interesting, while some of the animal models can recapitulate or show neuronal infection, the inflammatory responses are not the same in animal models as what we're finding in humans. So I think that's a limitation. You know, our approach to using the animals was in two ways. One was a very simple question about how reliable is CSF as a reflection of brain parenchyma when it comes to picking up virus. I was so excited when Eric proposed that experiment because, in the HIV field, of course, CSF is our gold standard for assessing whether someone has active brain infection or not. And it was interesting to me that even in a mouse that has robust brain infection, exponential growth, we're still not picking up anything in the CSF. I think it suggests that we have to take CSF findings with a grain of salt, at least when it comes to pathogen detection. And then of course the mouse brain staining is really not just using neuronal tissue. But yes, I think there are limitations, and that's why all of us, I think, try so hard to learn something from humans themselves, even though it can be more challenging sometimes.
Thanks. And so the other thought I had, of course, was, if we're measuring these specific antibody responses, which are very clearly different to what's happening in the blood, but they are responses to virus. Well, we look for virus in CSF and we don't see it, but clearly the virus is there in the nervous system. What are your thoughts on that? Where do you think virus actually is within the nervous system?
And why is it not in the CSF?
Yeah, and is it, when people have looked in neurons, I mean, the NIH meeting last week was fabulous, wasn't it? But certainly Avi Nath is pretty clear. He doesn't think there's much viral replication in neurons. Where do you think it is, and why is it not getting into the spinal fluid?
I think the jury's still out as to whether the virus is replicating in the central nervous system. All the evidence we have is indirect through the presence of antibodies. I think Avi's paper, I think he did show he couldn't find any, and the papers that did find it primarily through PCR or detection of antigen by immunostaining is not the same as finding replicating virus. So, I think the organoid models are really interesting. They're very helpful, but they're just at a model. And so I don't think we know the answer as to whether virus is replicating in the CNS or not.
Yeah. All right, lovely, thanks. We're going to thank you very much for that. We're going to move on now and get the update from Stuti Chakraborty from the JNNP blog team, who is going to tell us about some papers in the literature in the last month or so that have excited her. Go ahead and share your screen, Stuti. There we are.
So good afternoon, everyone. I'm going to be giving a very brief summary and highlights from the blog digest on behalf of the JNNP blog team. My name is Stuti Chakraborty, and I'm currently working as a junior occupational therapist at Christian Medical College, Vellore, in India. So the first study that was really interesting was on thrombosis with thrombocytopenia syndrome, TTS, and the AstraZeneca vaccine. So the TTS is syndrome associated with thrombosis in unusual sites like the cerebral venous sinus thrombosis, arterial bed thrombosis, which occurs usually post-vaccination. And so this article published in the journal Vaccine, led by McIntyre et al., compared the rate of TTS to other vaccines, and they found that that led to a policy change following rare adverse events in vaccinations post-rotavirus, smallpox, and oral polio. And their risk-benefit analysis was done on Australians aged between 18 to 59 years. They found that the estimated possible TTS cases was 347. And vaccine-related deaths were estimated to be 17 to 153, assuming that 80% of adults between the age group of 18 to 59 are vaccinated. So one of the limitations of this study was that the rate estimates were based on incidence following only the first dose, and there was an uncertainty in the rate of TTS as well. Coming to the next, again, vaccine-related study, which was quite interesting, was related to the mRNA vaccines in Mexico. And this was published in the journal Clinical Immunology. And Garcia Grimshaw et al. And their team did a large prospective observational study of first dose receivers on 704,003 people in Mexico. And according to the operational WHO definition of non-serious AEFI, which was first 30 days, that is adverse events following immunization, AEFI, first 30 days after the vaccination. And they defined it as something that does not pose imminent risk of death, disappears without treatment, or requires only symptomatic management, and does not significantly require hospitalization or cause any long-term disability. And AEFI was found to be reported in 6,563, of which 65.1% had already presented with at least one neurological AEFI. And 33 serious events were reported, and 17 of them were neurologic. And so the observed frequency was 2.4 out of every 100,000 doses. The next study was a very recent published one, just came out last week, and I believe Professor Solomon was one of the co-authors in this study. It talks about COVID-19 in children and adolescents, published in the Lancet Child and Adolescent Health, led by Ray et al. And so it was a prospective national cohort study by the Coronavirus Study Group, and pediatricians were asked to identify children and adolescents aged below 18 years with neurological or psychiatric disorders infected with SARS-CoV-2 and to have any relevant presentations. Children that were excluded were those not meeting the Royal College of Pediatrics and Child Health criteria for pediatric inflammatory multisystem syndrome, temporally associated with SARS-CoV-2, which is abbreviated as PIMS. -DS. And so the authors identified key differences between those with a primary neurological disorder versus those with PIMS-DS. So the interesting findings from this study were that between 2nd April 2020 and February 1, 2021, 52 cases were identified, out of which 51 were from England, and in a total population of 1,334, which leads to a case prevalence of 3.8 cases per 100. And 52% of, that is 27 out of 52 patients were classified into the COVID-19 neurology group, and 25 were classified into the PIMS-TS neurology group. So the PIMS-TS neurology group often exhibited multiple features like encephalopathy, peripheral nervous system involvement, behavioral change, and hallucinations at presentation. The last study that we would like to highlight from the blog from previous month as well as this month has been done by the team, the JNP blog team itself, led by Dr. Jonathan Rogers. So this talks about, it's a systematic review and meta-analysis of the early literature where we found that there were CNS manifestations related to COVID-19, and we described the key emerging narratives. So a total of 13,292 records were screened, of which 215 studies were included. 30 out of these, there were 37 cohort studies, 15 case control studies, 80 cross-sectional studies, and 83 case series from a total of 30 countries. And 147 of all the included studies were included for meta-analysis. So the symptoms that were most prevalent, with the highest prevalence, were anosmia, weakness, fatigue, dysgeusia, myalgia, depression, headache, anxiety, and altered mental status. Some of the major limitations of the study were the absence of comparison groups, which led to limitations in terms of the conclusion about the specificity of the symptoms of COVID-19. There were a lot of retrospective study designs. So that means that only those symptoms which had been inquired about could be included, and small sample sizes across the studies, which caused risk of reporting bias. So that brings me to the end of my presentation. Thank you so much for listening. If you would like to join us, please drop an email to Dr. Timothy Nicholson or messages directly on Twitter.
Thanks very much, Stuti. That's great. Lovely that you were able to present your own paper of the JNMP blog team's work. That's really good. And also thank you for showing our paper, which is actually led by my wife, Dr. Rachel Neen. She's the senior author. So I'll get some brownie points tonight. Now, Amrit, let's come over to you if you want to share your screen, and we're going to hear about your experiences in Pune in southern India, which for those who are not so familiar with that part of the world, is well known for having the big virology center, as well as I think it's the Pune Hospital and Medical Research Center where you work, isn't it?
Yeah. Should I share my screen?
Yes, please share your screen. Yeah. That's good. Great. We can see that now.
Yeah. Thank you, Dr. Solomon, and thank you for inviting me for the Neuro-COVID webinar. And I'll be talking today about neurological issues in COVID-19 patients in resource-limited settings. especially our experience from Noble Hospital and Research Center, Pune, during these last 15 months, which we have been managing COVID patients. To start off, today India is at a low ebb. We have finished the second wave. We have come down from 400,000 cases per day to 40,000 cases per day. The Delta wave was very, very severe in India, as you know, where we were having almost 4,000 deaths per day in the second wave as compared to 1,000 deaths per day in the first wave. So we have been very badly hit with the Delta variant in the second wave. Unfortunately, our vaccination is still crawling. We have been able to vaccinate around 400 million people, but still the first dose has been given to only 34% of entire Indian population, and only 8.5% of the Indian population is fully vaccinated. So you can see there are how many people are vulnerable to a third wave. It's humongous. Here is where I work. I work in Pune, which is in the state of Maharashtra. And this is the hospital where I work with, Noble Hospital and Research Center. We are a tertiary referral center. As of 18th of July, 2021, our state of Maharashtra has had 6 million cases of COVID-19 with 1,21,000 deaths. At our hospital, we have had 5,500 patients admitted with 399 deaths with an in-hospital mortality of 7.3%. And all of the data which I'm going to present is from our hospital, which we have experienced in the last 15 months. At our hospital, we have a neuro-COVID database in which all the central and peripheral nervous system complications, comorbidities, and symptoms are entered. And I am going to elucidate the unique characteristics and challenges which we have encountered. Majority of the data is from the first wave. The second wave data collection is still going on. By the end of the first wave, we had 2,800 patients, and 515 of them had severe COVID-19. That means at presentation in the hospital, they had a saturation of less than 90%, and they had respiratory or other organ involvement. I'm going to talk about the data of neurologic comorbidities, neurologic symptoms, and neurologic complications in patients with severe COVID-19, which have been stored in our database. This has been published in this mini review in Neuroscience Letters, and also some of the neurologic complications have been published in this paper, which is currently a medRxiv preprint, but will be published in Medicine Baltimore this week, in which we are also going to talk about neurologic complications in severe COVID-19. So coming to comorbidities, out of the 515 severe COVID-19 patients admitted with us during the first wave, 23 or 4% had concomitant neurologic comorbidities. Not surprisingly, cerebrovascular disease was the most common, but to our surprise, past history of poliomyelitis was a common comorbidity which was seen in patients with severe COVID-19. As you know, India has eliminated poliomyelitis in 2013, but prior to that, we have had multiple cases of young people coming with poliomyelitis and pre-existing neurologic deficit. And we believe that this population remains at risk of severe COVID-19, and we have certainly observed it during the first wave as well as the second wave, where people coming in with severe COVID-19 had past history of poliomyelitis with either paraparesis or monoplegia as a comorbidity along with severe COVID-19. Other comorbidities we saw was Alzheimer's disease, Parkinson's disease, psychiatric disorders like schizophrenia, cerebral palsy, myasthenia gravis, and epilepsy. What about neurologic symptoms? The most common neurologic symptom seen in our cohort with severe COVID-19 was myalgia, with almost 49% of patients coming in at hospital admission with the symptom of myalgia. Headache and dysgeusia or hypogeusia was seen in 11% of patients at admission, while anosmia and giddiness or unsteadiness during walking was seen in 4% of patients. What about incidence of neurologic complications? That means the complications which arose after the patients were treated for severe COVID-19. The most common was encephalopathy. That is a change in behavior, personality, or consciousness with no evidence of brain inflammation. It included the symptoms of delirium and coma as well. As you can see, 8% of our patients with severe COVID-19 developed encephalopathy, while out of those 44 patients, only 22% of patients were steroid responsive. That means after a pulse dose of methylprednisolone, there was a definite improvement in consciousness or definite improvement in delirium in only 22% of patients. The rest of the CNS complications which we saw was large vessel ischemic stroke leading to cerebral artery thrombosis, acute disseminated encephalomyelitis, seizures, intracranial hemorrhage, and acute transverse myelitis and GBS. When we looked at the risk factors associated with death in severe COVID-19, we clearly found that in those patients who died because of severe COVID-19, presence of encephalopathy was there in almost 25% of patients, while in those patients who recovered, only 2% of patients had encephalopathy. We had a mortality rate of almost 26% in our cohort of patients with severe COVID-19. Majority of them, almost 25% of those patients who died, had encephalopathy as a complication. When we looked at the relative risk analysis, we found that presence of encephalopathy had a risk of almost 9 times higher risk of death as regards not having encephalopathy in patients with severe COVID-19 on relative risk analysis. Moving on to other studies which we have done at our center, this is the first study which talks about cerebral venous sinus thrombosis as a complication of SARS-CoV-2 infection. And this is a multi-center study involving 5 hospitals from Pune, where we had looked at 34 COVID-associated cerebral venous sinus thrombosis cases amongst 14,805 patients admitted with COVID. We had found that incidence of CVST was higher in COVID-19 admissions as compared to non-COVID conditions. The incidence was 46 cases per 10,000 patients per year versus 25.2 cases per 10,000 patients per year. To our surprise, males were more affected by cerebral venous sinus thrombosis than females, although CVST is known to be a female-dominated disease, and there was no conventional risk factor seen in more than 75% of patients. Conventional risk factors like pregnancy, alcohol abuse, anemia was seen in only 25% of patients. Out of these 34 patients, 15 patients had symptoms of cerebral venous sinus thrombosis, but were asymptomatic for COVID infection. So when they were worked up for cerebral venous sinus thrombosis, positivity of SARS-CoV-2 was an incidental finding, while 19 patients had symptomatic COVID infection and symptomatic CVST. Out of these 19 patients, 14 had CVST during admission for COVID-19, while 5 patients had cerebral venous sinus thrombosis after discharge for severe COVID-19. Mortality due to CVST was seen in only the symptomatic group, and the mortality was almost 21%. 4 deaths occurred in the symptomatic COVID and symptomatic CVST group. A higher mean D-dimer was seen in the symptomatic COVID and symptomatic CVST group as compared to the asymptomatic COVID and symptomatic CVST group. So this was a study which will be published very soon in Indian Academy of Neurology journal this month. Moving on, we now move on to COVID-19 and other co-infections seen in our cohort. And the first disease which we have already published is COVID19 CNSTB co-infection. We have reported 3 cases of mild COVID disease and CNSTB co-infection. All these 3 cases had mild COVID disease. They had no evidence of pulmonary TB and no evidence of HIV infection. They presented with symptoms of fever, headache, projectile vomiting, and on imaging studies were found to have tubercular granulomas in the brain. The CSF showed lymphocytic pleiocytosis, and the CSF CBNAT or PCR was positive for Mycobacterium tuberculosis. We do not believe that COVID-19 is one of the reasons for CNSTB co-infection. We believe that India is a high COVID, high TB burden setting, and it is just an intersection of the 2 epidemics which have led to cases of CNSTB being seen, CNS tuberculosis being seen in COVID-19 infection. Out of these 3 cases, 1 patient progressed to coma and died, while the others made a complete neurologic recovery. These are the MRI images. You can see in the parieto-occipital lobe, multiple grape-like granulomas along with a strong perilesional edema and meningeal inflammation is seen on MRI. Moving on to the second co-infection, which I'm sure Dr. Kameshwar Prasad will talk in the future slides, is about COVID-19 associated mucormycosis. As he rightly said, India is now seeing a second epidemic of mucormycosis amongst COVID-19 patients, and we are presenting the data of 57 patients of COVID-19 associated rhino-orbitocerebral mucormycosis in our hospital. We believe COVID-19 associated immunosuppression, concomitant diabetes mellitus, irrational use of steroids for mild and asymptomatic COVID disease, and hyperferritinemia during COVID are common risk factors why India is seeing such a big epidemic of rhino-orbitocerebral mucormycosis. Median duration between diagnosis of COVID-19 and diagnosis of mucormycosis was 15 days in our hospital. 56% of patients had orbital involvement with either one eye or the other eye involved, while 44% of our patients had cerebral involvement. That means either meningitis or frontal abscess or the skull base being eroded. 24% of patients needed exenteration of an eye, while 9% of patients needed neurosurgical intervention with removal of frontal lobe abscess. The mortality rate in our cohort was 24%. That means 14 deaths out of 57, while we were successfully able to discharge 43 patients from our hospital. While in our patients with cerebral extension, that means rhino-orbitocerebral mucormycosis, mortality amongst those 25 patients with cerebral extension was almost 48%. You can see these are the MRI pictures of the cerebral mucormycosis, COVID-associated cerebral mucormycosis, the frontal abscess, which is clearly seen over here. And you can even see the exenteration, which is done in these lower slides of patients who had orbital involvement with proptosis and loss of vision. Similarly, here you can look at these frontal abscesses and the perilesional edema in the frontal area, which is seen in patients. And here you can see the exenteration which has been done of an eye to remove the deceased eye. What were the challenges which we encountered during managing these CNS complications in COVID-19? Number one, we had an overwhelmed healthcare system and an inadequate workforce, because of which lower incidence of neurologic symptoms and comorbidities could have been reported in our cohort. As regards neuroimaging, it was scarcely there in patients who were admitted in semi-urban and rural settings. Nerve conduction studies and CSF examination was not routinely available, especially in patients who were on non-invasive or invasive ventilation. Similarly, availability of neurologists for bedside or remote assessment through telemedicine was not routinely available, because of which multiple times the decisions had to be taken by the intensivist or the physician on call. Similarly, multiple modalities of treatment for acute disseminated encephalomyelitis, GBS, like IVIG, plasmapheresis, and even liposomal amphotericin B for cerebral mucormycosis was in short supply because of the rapid surge in mucor cases seen during the second wave. So in conclusion, pre-existing neurologic comorbidities are associated with higher mortality in our cohort, with almost a mortality of 50% if you have a neurologic comorbidity, while 26% was the mortality for the entire cohort. Neurologic symptoms are seen in almost 50% patients with severe COVID-19 in our cohort. Secondary neurologic complications like encephalopathy, which was most common, and stroke develop in approximately 9% of patients with severe COVID-19. Cerebral venous thrombosis, venous sinus thrombosis is an uncommon but significant complication of SARS-CoV-2 infection, and all these cases which were reported were not related to vaccination. They were all in unvaccinated individuals. And other CNS infections like CNS tuberculosis and rhino-orbitocerebral mucormycosis are observed in COVID-19 patients in resource-limited settings like India, and now even countries like Bangladesh and Nepal, which are bordering India, are reporting cases of mucormycosis associated with the COVID epidemic. Thank you for patiently listening, and I'll take whatever questions come my way.
Thank you. I mean, thanks. That's a super body of work. I knew you'd done a lot. I hadn't quite realized how much you and your colleagues had been doing. So please, if people would like to post their comments or questions to Amit, or indeed any further questions or comments to Shelley, that would be great. Maybe I'll start, Amit. I thought your data on steroids and tocilizumab were very interesting, that you have given these drugs to patients. Clearly now these are indicated for anyone with severe COVID, but I think you said about a quarter of them appear to improve in terms of an improvement in their coma score or delirium. Do you, so two questions really, are you formally calculating, you know, are you, what scores are you using to determine whether people have improved? And then secondly, is there anything different about those who improve neurologically with those who do not? Are there any clues as to who's going to benefit?
That's a very nice question. Majority of these patients who developed encephalopathy in our cohort were in the ICU. They were on non-invasive or invasive ventilation. And then on day 7 or day 8, especially during the inflammatory phase, they suddenly developed encephalopathy. we believe that the encephalopathy was a part of the cytokine storm which was occurring in the body. So whatever was happening in the lung was replicating itself in the brain, because of which there was brain inflammation and because of which they were having an altered sensorium. The problem with our hypothesis is that then if it was cytokine storm in the brain, then with high dose steroids, majority of them should have improved. But only 22% of those patients improved. Majority of those who improved were young, they were males, and they had a lower lung involvement along with CNS involvement. While the patients who deteriorated were elderly, especially more than 75 years of age, they were more females, and especially obese individuals did not respond. We feel that maybe, as Shelley has said, that maybe the biomarkers in the brain are different from the biomarkers which control inflammation in the lung. That is why maybe we need targeted therapy for encephalopathy in the brain, or because we had no imaging available to diagnose the cause of encephalopathy, it could have been that we have given steroids for patients who maybe had intracerebral hemorrhage or maybe had a granuloma or something else. So that was not possible because imaging was not available in the ICU.
So you think there might be a difference. I don't know if Shelley's still there and wants to turn her camera on and microphone on. Yeah, great. What's your feeling? I mean, these. I did mean to ask this earlier. These patients where you've got the CSF and you're looking at that, were they mostly encephalopathic patients, or did they have other problems? And do you feel you will be able to distinguish the immune responses according to the different clinical neurological phenotypes?
Yeah, it's difficult because we only ever get CSF from people who are undergoing LP for clinical indication. So we know we're missing everyone on the milder end of the spectrum. And so it's unknown whether what we're seeing is a marker of severe or even of neurological symptoms, whether even neurologically asymptomatic people would have, for example, antiviral antibodies in the CSF. Would they have antineural antibodies in the CSF? We don't know the answer to that. I have my own suspicions that I don't think this is going to be specific to the most extreme cases. In terms of the symptoms of the patients that we did assess, about half were encephalopathic, and the rest, a couple had a bad headache, but were completely, conversant during their lumbar puncture, for example, really only had a bad headache, and that's why they were getting the LP. And then one had seizures. So in that sense, no. And the staining patterns, again, with a very limited N, also don't correlate at this time with specific symptoms. So no, but I will say that I didn't have a chance because the time ran out. We have had a couple of cases, and I'll say this work was done in collaboration with Dr. Serena Sputic and others. We had a couple of cases of post-acute COVID, new onset psychosis that we have examined the CSF and again found antineural antibodies using the methodologies that I talked about today. And those patients, again, a very small number, did respond to immune treatment, so IVIG and steroids. So, whether those factors are related or not, I can't say, but just as a beginning.
You also,
can I say something, Dr. Solomon?
Go ahead, please do, yeah.
Yeah, because the other thing is that encephalopathy is multifactorial. So it could be hypoxic, it could be metabolic, it could be drug related. The problem is in an ICU, it is so difficult to differentiate what is causing encephalopathy. And because the mortality during the first wave was around, in our hospital, 5%, while it jumped to 12% during the second wave, that we gave methylprednisolone to majority of the patients who developed encephalopathy, but there could have been other factors which could be responsible for encephalopathy. So maybe he had hypoxia and oxygen was not reaching his brain, which was causing encephalopathy. But unfortunately, such patients also ended up getting methylprednisolone, although we covered it up with prophylactic antifungal therapy to prevent mucor and to prevent breakthrough fungal infections, which we were seeing in our country. So it could be multifactorial, and that's why only 22% patients actually improved after giving methylprednisolone.
And so I know you're an infectious disease and HIV specialist. So you must have, I guess, seen lots of patients on intensive care with all sorts of other complications. Do you feel that there's more encephalopathy in these patients with COVID than you would expect compared to other severe, infections?
Yes. So as regards to other infections, COVID definitely is much more neuroinvasive as compared to, say, HIV. Maybe acute neuroinvasion is much higher, and neurologic complications are much higher in acute COVID, which I've seen in my practice.
Yeah, just a couple of other comments from the chat for both of you, actually. First of all, for Amit, the question is around the mucormycosis, and do you think it's associated with drugs and other treatment measures used in India? And also, I was going to just add to that, and again, because you're an infectious disease doctor, I can share with you some of my ID ignorance. But when I was started in Asia, there used to be a disease called melioidosis, caused by something called Pseudomonas, which I think they've renamed it Burkholderia. But that used to be a disease of the immunosuppressed and diabetics. So are we seeing more of that in these patients as well, or is it just the mucormycosis?
No, we have had multiple infections which we are seeing. The commonest is breakthrough fungal infections like candidemia, aspergillus, and mucor. Then we see a lot of herpes zoster, herpes simplex, and varicella zoster, like what we call as disseminated varicella, and even CMV infections. So most common in our center is candidemia, aspergillus, mucor, and then herpes simplex, herpes zoster, and varicella zoster. Herpes group of viruses, which we are seeing much more commonly.
Yeah, and there was a question, I think it was from Angela, and this I think directed to you, Shelley, or either of you, about you know, the fact that we're not, if you don't get cells in these patients in the CSF, do you feel that the pleiocytosis, cells in the CSF, is a poor reflection of what's really going on in the brain? Just perhaps like, you know, trying to detect virus there is a poor reflection of what's going on in the brain?
Yeah, you know, it's a really good question, and it's something that we have experience with from HIV as well, that the pleiocytosis is a crude marker of inflammation in the central nervous system, and it certainly doesn't tell you anything about genetic pathway changes or activation of the cells that are there. So unless the cells are increased in number by quite a lot, and then you could be fooled by a normal CSF white blood cell count into thinking there are no immune changes in the CSF. But we know from, you know, decades of work in HIV that even in individuals who have a normal CSF white blood cell count, which is the majority of our patients with chronic HIV infection, we're still seeing pretty robust gene expression changes within the CSF immune cells. So I think that's sort of how I would approach pleiocytosis. And now we know from all the studies that have been published in acute COVID-19, and a really nice review article that came out a couple of weeks ago, it's from the NYU group, and I don't remember the name of the first author right now, that pleiocytosis is exceedingly uncommon in patients with acute COVID-19 who undergo LP.
Yeah, brilliant.
Dr.
Okay,
Solomon, the one question you asked about mucor. So we firmly believe that steroids are used extravagantly in India, especially in people with asymptomatic and mild COVID disease, and their usage increased because there were so many cases that physicians panicked when patient came to them in the OPD saying that I have these symptoms, and even asymptomatic and mild COVID cases got prescribed steroids. And we always say that steroids should be reserved for hypoxic individuals. And there you have it. If you prescribe it to non-hypoxic person, then you do run the risk of making him susceptible, especially if he is a diabetic and COVID positive, to mucormycosis. And the example is clearly in front of everyone.
Thank you. Let me just, before I disappear, thank Amit Dravid, Shelley Farhadian, and also our JNNP blogger, Stuti Chakraborty, for some wonderful presentations. So thanks very much.